Hello everyone, Mr. Linder here. Let's talk about regulation of the GFR or glomerular filtration rate. So the glomerular filtration rate can be regulated by both intrinsic and extrinsic mechanisms. The intrinsic mechanisms take place within the kidney, and these are used to maintain GFR in the face of systemic blood pressure changing. The two mechanisms for the intrinsic response to regulating the GFR are the myogenic mechanism and the tubuloglomerular mechanism. The myogenic mechanism is basically a response from the vascular smooth muscle when blood pressure changes systemically. The tubuloglomerular mechanism is a paracrine signaling mechanism in which it responds to flow rate and fluid rate changes within the nephron to influence what's happening to the glomerular filtration rate. Extrinsic mechanisms, the renin angiotensin system and nervous system control mechanisms, are essentially utilizing systems that have changes that take place outside of the kidney, and then they influence changes within the kidney in order to change the glomerular filtration rate. What you're looking at on this particular summary diagram is what happens when there's low blood pressure changes. When there are decreased blood pressure systemically, so when there's lower blood pressure coming into the renal artery of the kidney, there are these intrinsic and extrinsic responses that can take place in order to increase the glomerular filtration rate. You could also, though, look at this diagram on the flip side. We could reverse what's happening and we could look at changes when blood pressure increases. So if there was an increase in blood pressure, we'd be looking at things that decrease the glomerular filtration rate. So let's take a look, though, at both types of systems, intrinsic and extrinsic, and we'll take a look at when blood pressure is dropping, and we'll also take a look at when blood pressure is increasing. So let's start with the myogenic mechanism. So the myogenic mechanism responds when your blood pressure drops in a way that will increase the GFR. So if pressure decreases coming into the renal artery, that means there's going to be less pressure coming into the afferent arteriole. If there's less pressure coming into the afferent arteriole, that would result in essentially a drop in the filtration rate. So what the kidney does intrinsically is it maximally dilates, or it vasodilates the afferent arteriole to improve the blood flow into the glomerulus so that you can increase the GFR. So when there's a drop in blood pressure, there's a vasodilation of the afferent arteriole to increase the GFR. So the reverse of that, if there was an increase in systemic blood pressure, that would actually cause the afferent arteriole to begin to stretch, and the response of the muscle stretching in the afferent arteriole would be to open calcium voltage-gated channels and allow calcium to trigger muscle contraction and cause a vasoconstriction of the afferent arteriole. So if we had increased blood pressure, we would see a vasoconstriction of the afferent arteriole, and that would lead to a decreased glomerular filtration rate because you'd have less blood entering the glomerulus, and so less filtration happening into Bowman's capsule. Now, there is a scenario, though, where the pressure could get too low. For example, if you have pressure that's below a mean arterial pressure of 80. So if we drop our MAP pressure below 80, the arterioles can't vasodilate anymore to increase GFR. And so if we drop below 80, we're actually going to see GFR decrease. And that's going to impede our filtration of our blood, and that's going to impede the natural function of the kidneys. So our kidneys work well when mean arterial pressures stay within 80 to 180 millimeters of mercury. If we drop too low, we'll actually be unable to increase the GFR, and we'll actually then be seeing the GFR decrease. So that's the myogenic intrinsic mechanism. The tubuloglomerular intrinsic mechanism actually involves macula densa cells. The macula densa cells are actually part of a structure called the juxtaglomerular apparatus. So if we look at that anatomically, here we have the afferent arteriole. That's for blood coming into the glomerulus. So glomerulus. And then we have the efferent arteriole, and that's for blood going out of the glomerulus. These cells that are along the loop of Henle or even distal convoluted tubule, these cells are going to be the macula densa cells. And so the macula densa cells can release chemical signals. So there's signals that can be released from these cells that can affect the afferent arteriole. And so that's, in essence, how the tubuloglomerular feedback mechanism is going to work. It's going to be paracrine signaling from the macula densa cells affecting the smooth muscle of the afferent arteriole. There's also these granular cells that line the afferent arteriole. Those granular cells actually produce renin. And so renin will be an important part of the extrinsic regulation of the GFR. So we'll take a look at that in a little bit. So let's go back and look at our diagram. So the macula densa cells are part of this tubuloglomerular feedback mechanism. So what's happening in this scenario? Well, when there's low blood pressure, so when we have decreased blood pressure, we're going to have reduced flow, reduced concentrations of particles flowing through the loop of Henle, through the distal convoluted tubule, and that reduced flow is going to affect our filtration rate. So when the kidneys are experiencing reduced flow, we need to increase the GFR. So decreased flow, decreased salt delivery would actually result in paracrine signals getting released that are going to cause vasodilation of the afferent arteriole. So when that afferent arteriole opens up, we can increase the GFR. The flip side would be if there was increased flow, increased salt delivery through the loop of Henle and the distal convoluted tubule, and that would be the result of an increased systemic blood pressure. So what we'd see in that scenario, if we had an increased blood pressure and we had increased flow, then we would see vasoconstriction. So just like we saw with the myogenic mechanism, we'd see vasoconstriction of the afferent arteriole, and that would decrease the GFR. So vasodilation increases the GFR, vasoconstriction decreases the GFR. And so we use these macula densa cells and the signals that come from the macula densa cells to either vasodilate or vasoconstrict the afferent arteriole based on the flow through the nephron. So these are our intrinsic mechanisms to regulate GFR. The extrinsic mechanisms to regulate the GFR involve the sympathetic nervous system, so neural control, and then it also involves the renin-angiotensin system, so the release of renin from those granular cells of the juxtaglomerular apparatus. So two extrinsic mechanisms to regulate glomerular filtration rate. So let's take a look at the sympathetic nervous system first. So if you have decreased blood pressure, what is the sympathetic nervous system going to do? Well, the sympathetic nervous system innervates the afferent and efferent arterioles inside the kidney. So we can either vasoconstrict or vasodilate internally, but predominantly what we see is actually the effects on systemic arterioles. So even though we can vasodilate and vasoconstrict internally, a lot of the extrinsic control is because we can affect systemic arterioles. When the sympathetic nervous system is essentially responding to a drop in blood pressure, we're going to see the vasoconstriction of systemic arterioles, which is going to increase peripheral resistance. That's going to lead to an increase in systemic blood pressure. And if we can increase systemic blood pressure, we can increase the overall GFR. So predominantly what we see with the sympathetic nervous system extrinsic control is a way to increase glomerular filtration rate when we have a drop in blood pressure. If we had an elevated blood pressure, we wouldn't need the sympathetic nervous system to affect what's going on because there's already elevated blood pressure. What about the renin-angiotensin system? So the renin-angiotensin system is designed to essentially produce angiotensin 2. So we need to produce angiotensin 2, and we need to release the hormone aldosterone in order to get changes in glomerular filtration rate. So renin, as I mentioned earlier, is released from the granular cells around the afferent arteriole, so it's part of the juxtaglomerular apparatus, and it's released in response to a drop in blood pressure. So drop in blood pressure, it's also released when there's increased sympathetic activity, and there's also even paracrine signals from the macula densa that can affect the release of renin. But the direct effect on the release of renin is a drop in systemic blood pressure. So when there's a decrease in blood pressure, we're going to see the release of renin. Renin goes out into systemic circulation, and it activates a plasma protein called angiotensinogen. So I want to show you a summary of what that looks like. So the direct effect on the release of renin is the drop in blood pressure. So this is the renin-angiotensin pathway, and that drop in blood pressure is our direct effect on the juxtaglomerular apparatus, so the granular cells of the afferent arteriole, to release renin. We see sympathetic activity, we see paracrine signaling from the macula densa as other ways to release renin, but that direct pathway is a drop in blood pressure. When renin gets into circulation, it's going to activate a blood protein called angiotensinogen. Angiotensinogen is produced by our liver. So our liver produces angiotensinogen, puts that protein, this inactive protein, into the blood, and it's activated by renin when there's a drop in blood pressure. So we could say something like angiotensinogen is going to be activated into a protein called Ang1, so angiotensin 1, and that's done by renin. So renin converts angiotensinogen into angiotensin 1. Angiotensin 1 continues to circulate in the blood plasma, and angiotensin 1 is going to be activated by an enzyme called angiotensin converting enzyme. So angiotensin converting enzyme is abbreviated ACE. So Ang1 can become Ang2, so angiotensin 2, when it encounters the enzyme ACE. And ACE is produced by endothelial cells within the cardiovascular system. So Ang1 becomes Ang2 when angiotensin converting enzyme activates it. Once you have angiotensin 2 circulating in the plasma, then you can get the effects of angiotensin 2. And one of the primary effects of angiotensin 2 is to be a vasoconstrictor. So vasoconstriction of systemic arterioles is going to lead to an increase in blood pressure. And if you can increase blood pressure, you can increase glomerular filtration rate. So when you have a drop in blood pressure and you activate this extrinsic system, angiotensinogen becoming Ang1, Ang1 becoming Ang2, angiotensin 2, you can use angiotensin 2 as a vasoconstrictor. That's going to increase systemic blood pressure, and that's going to lead to an increase in GFR. The other thing to take a look at is the effects of angiotensin 2 on the adrenal cortex to release aldosterone. So aldosterone hormone, a steroid hormone, is actually used to increase sodium retention, so increase the sodium reabsorption in the kidneys. That's going to lead to an increase in blood volume. Increase in blood volume results in increased blood pressure, which again ultimately leads to an increase in glomerular filtration rate. So if we look at angiotensin 2, and if we focus on the molecule angiotensin 2, what we can look at is its tissue actions. So angiotensin 2 affects the adrenal cortex and the release of aldosterone. Angiotensin 2 causes vasoconstriction, and then there are some other functions that we'll take a look at in a minute. But vasoconstriction increases blood pressure because aldosterone increases sodium retention. That leads to an increase in blood pressure, and these will increase GFR when we have a drop in blood pressure. So let's take a look at aldosterone as well. This is a nice summary diagram for aldosterone. And again, look at the tissue effects. So the renin-angiotensin system, this extrinsic mechanism, affects the adrenal cortex. It triggers the release of aldosterone, and we get an increase in sodium reabsorption. And that increase in sodium reabsorption is leading to increases in water retention, increased blood volume, increased blood pressure, increased GFR. What you should also notice, though, that when you have aldosterone secretion, is that you get the secretion of potassium. So we retain sodium and get rid of potassium under the effects of aldosterone. So angiotensin 2, not only is it a vasoconstrictor, but it also stimulates the release of aldosterone, which helps us to retain sodium and get rid of potassium. So if we look at a summary of functionality within the kidney for aldosterone, we'll see that aldosterone, steroid hormone, enters into cells, cuboidal epithelial cells of the nephron. Those aldosterone signals affect transcription and ultimately translation. The translation process basically induces proteins to modify, so we're going to modulate existing channels and pumps that affect the movement of sodium and potassium. So we get potassium dumped into the nephron lumen. So we have potassium secretion. That means that potassium is destined for excretion. We're going to lose potassium from the body. And then we see that sodium ends up in the blood. So we are retaining sodium and that will lead to increased water retention, which increases blood volume, which increases blood pressure, which is why we see a change in systemic blood pressure, which ultimately leads to an increase in GFR in that extrinsic mechanism. So aldosterone has the ability to retain sodium and secrete potassium. What are some of the other effects that we see with angiotensin 2? So besides angiotensin 2 being a vasoconstrictor and also controlling the release of aldosterone, we also see that angiotensin 2 increases antidiuretic hormone release. So vasopressin is another name for antidiuretic hormone. Antidiuretic hormone helps to retain water in the kidneys, which is going to mean more blood volume, more blood pressure, and thus can affect glomerular filtration rate. But of course, it's affecting our overall blood pressure. So this is a way to assist in increasing blood pressure. We also know that angiotensin 2 stimulates thirst in the hypothalamus. So we're actually looking at, these are neural effects. So this is systemic arterial effects. This is adrenal gland effects, and then this would be neural effects. So stimulating thirst is a neural effect. Increasing thirst increases blood volume, thus increases blood pressure. Angiotensin 2 also activates the cardiovascular control centers, which affects the sympathetic output. Increased sympathetic nervous system is going to increase heart rate. So we're talking about increased cardiovascular responses. So increased sympathetic output increases heart rate. It affects vasoconstriction of blood vessels, and so thus we are increasing overall blood pressure. Angiotensin 2 also we know is affecting the nephrons clearly through the effects of aldosterone, but it also has an influence directly on the proximal convoluted tubule in terms of increasing sodium reabsorption. So we get increased sodium reabsorption directly from the proximal convoluted tubule, and then we also get it from the aldosterone response. So angiotensin 2 has many effects on the body, primarily looking at increasing blood pressure and also how it increases overall glomerular filtration rate. Because angiotensin 2 has increased blood pressure effects, there are actually ways to control blood pressure by controlling the angiotensin pathway. So some of the clinical aspects for this would be ACE inhibitors, medications called ACE inhibitors. If you take an ACE inhibitor, that's going to prevent the conversion of angiotensin 1 into angiotensin 2, because that pathway is based on the enzyme ACE, angiotensin converting enzyme. So if you take an ACE inhibitor and block ACE, you thus can block the production of angiotensin 2 and thereby lower blood pressure in your patient. There's also what are called angiotensin receptor blockers, or ARBs. These are drugs that actually affect the angiotensin 2 receptors. So if you are blocking the receptors and not allowing angiotensin 2 to interact with those receptors, that will decrease the overall vasoconstriction that we see, and thus we would be able to lower blood pressure. So ARBs are another good clinical pharmaceutical that can be used to lower blood pressure. And then there are also direct renin inhibitors. So if you can inhibit renin, Renin is what started the whole process because renin converts angiotensinogen into angiotensin 1. So if you take a direct renin inhibitor, that's going to shut down the renin angiotensin system and thus can be used to lower blood pressure. So from a clinical standpoint, ACE inhibitors, ARBs, and direct renin inhibitors can disrupt this renin angiotensin system and thus can clinically lower blood pressure for patients that are suffering from hypertension. So that's a little bit on regulating the glomerular filtration rate from both intrinsic and extrinsic mechanisms. I hope that helps. Take care.